Hi, my name is Ghazal Farajadeh. I'm a fourth-year medical student at Florida State University College of Medicine, and I'll be discussing our study on the association of integrase inhibitors and hypertension in HIV patients. To discuss a little bit of background, as patients are aging with HIV and comorbidities of diabetes and weight gain become more relevant, incidences of hypertension have also increased. Additionally, as numerous first and next-line HIV regimens include integrase inhibitors as a component of combined antiretroviral therapy, there is a concern for a correlation between the drug class of integrase inhibitors and hypertension. The objectives of our study were to identify the relationship between integrase inhibitors and hypertension, to correlate the occurrences of hypertension with regards to patient demographics, and considering comorbidities, does weight, diabetes, and renal disease affect results? The methods included a retrospective collection of electronic medical records using our local medical clinic at Midway Specialty Care Center in Fort Pierce, Florida, between the dates of January 1st, 2018 and February 6, 2022, who have a confirmed diagnosis of HIV. Using the ICD-10 codes of I-15.1 and I-10 to account for hypertension, sex, race, age, diabetes, and weight were correlated to identify a relationship between hypertension and integrase inhibitors. Patients taking integrase inhibitors were classified in Group A, and non-integrase inhibitors were classified in Group B, and the regimen separated the two cohorts. The drugs included in the integrase inhibitor group are listed in this box above and include Biktarvy, Cabenuva, Tivicay and Tivicay PD, Dovato, Genvoya, Stribild, Triumec, Juluca, Icentris, and Icentris HG. We initially divided the two groups of Group A and Group B, Group A being our integrase inhibitor group, with patients with hypertension and without hypertension. As seen, both groups have very similar rates of hypertension, Group A at 39.9% and Group B at 37.8%. These groups were then further divided based on demographics and comorbidities. As also seen between these two charts, both groups had similar rates of comorbidities and very similar in their demographics. Moving on to results, among Group A, our integrase inhibitor group, 39.9% were diagnosed with hypertension. In comparison, 38.7% were identified with hypertension in Group B, our non-integrase inhibitor group. The distribution of sex between the two groups was nearly similar, as was race, ethnicity, and occurrence of diabetes. An older population of over 50 was identified in Group A at 62.1% compared to 54.2% found in Group B. Diabetes was more relevant in patients not taking an integrase inhibitor by 3.9% with a rate of 69.2%. Overweight or obesity totaled 64% for those taking an integrase inhibitor compared to 56.8% in those not. Furthermore, Group A concluded a higher instance of hypertension and male demographic with a younger demographic and less distribution of Black or African Americans. The odds of developing hypertension were not significantly higher among those taking integrase inhibitors, at an odds ratio of 1.09 and a 95% confidence interval between 0.85 to 1.39. In conclusion, with the outpouring amount of regimens available, long-term management of HIV should include consideration of hypertension. Our single-site review considered the correlation between hypertension and integrase inhibitors and did not reveal an association with integrase inhibitors to an increase in hypertension. However, a larger data pool will be essential to analyze HIV medication classes and their possible correlation to hypertension. Thank you for your time.